Bismillah ar-Rahman ar-Rahim. Our students of grade 4, I will talk about a kidney function test included in urinary system biochemistry session, and I will divide this lecture into two parts, and its official time is 3 hours by Dr. Basil Awaid. The objective of lecture, I will talk about the nephron functions and the regulation of electrolyte balance. Also, I will talk about substances related to kidney functions and diseases. Then, define and differentiate proteinuria types and chronic kidney failure and related biochemical investigations, acute kidney failure and related biochemical investigations. Finally, I will talk about some kidney diseases and kidney stones. Kidney functions. The functions of kidney are to maintain the homeostasis of extracellular fluid involving the water volume and its components. And these functions need for the following functions. The first, excreting the waste product of metabolism, urea, creatinine, hydrogen ion, and so, and also excretion of surplus amount of inorganic materials that present in ingested diet, like sometimes extra amount of sodium, potassium, calcium out of their homeostasis that must be excreted. The substances to be filtrated by the glomerulars must be water soluble. The second, retaining of essential substances. Substances may be prevented from filtration according to their volume and charge, or may be filtrated, but they are essential and so reabsorbed, like glucose, amino acid, vitamin. The third, maintaining of correct balance. That's mean homeostasis of the water, irrespective of daily intake, electrolyte, minerals, by regulation of their secretion and reabsorption. The fourth function of the kidney is as endocrine gland, synthesize and secrete several important factors like erythropoietin, which is secreted from the kidney in response to hypoxia and is a potent stimulator of erythropoiesis in bone marrow, and so there is a relation between kidney failure and anemia when this factor is absent in diseased kidney. Renin, which is a part of renin-angiotensin aldosterone system, and 1-alpha hydroxylase enzyme synthesized and secreted by proximal tubules and responsible for formation of 1,25-dihydroxy vitamin D, D3 or D2, that is responsible for intestinal absorption of calcium and phosphate. Kidney is formed of more than 1 million of functional unit nephrons. Nephrons usually start with a capsule, human capsules, in which glomerulus is enclosed. Glomerulus function in formation of urine by filtration of plasma, and this filtration leads to passing of a water, of fluid, and components through the pores of glomerulus. The basement membrane of glomerulus is negatively charged due to abundance of sialic acid carbohydrate structure in it, and so repel those large anions like protein and preventing them from entering through these pores, from these pores. So the filtrate will be referred to ultrafiltrate, and it is compositionally similar to that of plasma, with the exception of absence of that protein that prevented it from entrance and also from blood cells. Renal tubules. Proximal renal tubules, it is the most metabolically active part of the nephron. The loop of Henle, descending and ascending. Ascending limb, thick ascending limb is rich in sodium chloride pump and responsible for reabsorption of chloride and sodium, but it is water impermeable, so the fluid that emerges from the end of the loop of Henle is hypotonic. Juxtaglomerular apparatus is an important apparatus that is next to the glomerulars in position and responsible for secretion of renin, which is part of renin-angiotensin-aldosterone system that is stimulated the conversion of angiotensin gene into angiotensin 1, and angiotensin 1 travel to the lungs where there is converted into angiotensin 2 by angiotensin converting enzyme that is subjected to drugs of use in hypertension. Angiotensin 2, it is a vasoconstrictor. It is responsible for reabsorption of proximal sodium and also stimulated the synthesis and secretion of aldosterone from adrenal cortex that result in reabsorption again of sodium and exchange of potassium at collecting duct. In proximal convoluted tubules, around 60% of the sodium that is filtrated will be reabsorbed, depending mainly on sodium hydrogen exchanger at the apical side of the epithelial renal tubules. That means sodium will reabsorb in exchange with hydrogen ion. Sodium will be transported from the lumen into the renal tubule cell, and the hydrogen will be secreted from the renal tubule cell into the lumen. And this usually continued in the presence of basolateral sodium potassium ATPase. That is the result in providing of energy enough to transport of the absorbed sodium from the intracellular into the blood to provide a gradient for continuous reabsorption of sodium. A variety of apical sodium co-transporter also allow for reabsorption of other organic glucose, amino acid, and inorganic chloride, calcium, phosphate, bicarbonate for reabsorption. Final sodium balance usually is achieved in the collecting duct via selective amyloid diuretic drugs that usually used to treat of hypertension and edema, mainly in cirrhotic and congestive heart failure patient. Amyloid sensitive epithelial sodium channel, which is accompanied by movement of potassium into the lumen. That means sodium will reabsorb as the collecting duct via this epithelial channel, and the potassium will be secreted into the lumen by potassium chloride importer or by potassium channel. This channel of the sodium, epithelial sodium channel, is usually under control. There is a receptor at it for binding and exertion of the action of aldosterone. So at the collecting duct via the sodium epithelial sodium channel, the reabsorption of sodium will be controlled by aldosterone. Aldosterone will enhance the reabsorption of sodium and excretion of potassium ion. Several pathological condition may be found at the site of renal tubules, Cohn syndrome, Addison syndrome, renal tubular acidosis type 1 present. A mutation, genetic mutation in sodium, potassium, chloride, electroneutral channel that present at the thick ascending limb of lobe of the Henle, and also a mutation in ROMIC1, renal outer medullary potassium channel, usually cause of Bartter syndrome. Liddle syndrome is characterized by mutation that lead to an increase in epithelial sodium channel activity that result in increased reabsorption of sodium and consequent excretion of potassium and hydrogen ion. At the distal tubules, there is a tight and final regulation of calcium reabsorption and define the final excreted amount of calcium. At this site, distal tubules, usually calcium is reabsorbed via epithelial calcium channel under control stimulation of parathyroid hormone. So the net amount of excreted calcium is finally regulated at distal tubules under control stimulation of parathyroid hormone, which at the same time this hormone, parathyroid hormone, will lead to inhibition of phosphate reabsorption. The reabsorption of calcium is stimulated by active vitamin D that stimulate the increased amount, that means expression of this channel of calcium. Vasopressin, antidiuretic hormone, is very important for solute free water reabsorption. Usually this occurred by its stimulation of equiporins migration from the site of the synthesis in the cell ribosome to the cell membrane and its incorporation. That means incorporation of equiporin into the cell membrane and enhances the uptake of water. Water movement across the membrane needs for equiporins channel that is stimulated by vasopressin. Then water will be moved according to the osmotic gradient between the lumen and the renal epithelial cells, and resulting in what? In excreting of concentrated urine. Otherwise, absence of antidiuretic hormone result in excretion of hypoosmolar urine along with hyperosmolar plasma, which may occur usually in diabetes insipidus, which is of two types, either central or neurogenic diabetes, in which the antidiuretic hormone is absent due to the damage of brain, hypothalamus or pituitary components, or nephrogenic, in which the channels or receptors for antidiuretic hormone is absent due to the diseased renal tubules, result in both polyuria with diluted urine. The function of renal to excretion of the waste product and extra amount of non-organic material ingested into the diet, usually achieved by two functions of the kidney, excretory function and reabsorptive function. And the efficiency of the homeostatic role of the kidney usually is illustrated by homeostasis of sodium, which maintained within the normal range, irrespective of daily sodium intake, whether it is low, 1 millimole in the diet, or maybe high, 150 millimole in the diet. Depending on the activity of renal tubules, capacity, reabsorption, excreted amount of materials in the urine in general less than that filtrated. Excreted amount of components in the urine usually less than that found in the filtrate, which means several reabsorption capacity of renal tubules. Urination is the formation and discharge of urine, usually in adult, range between 400 to 2000 milliliter per day. Abnormality in excretion of water when it is a low volume, less than 100 ml daily, referred to anuria or liguria when it is more than 100 to less than 400 milliliter per day, and polyuria when it is much amount of urine is excreted, more than 3 liter per day. Usually for unit is calculated as milliliter per kg body weight. Each nephron approximately filtrate 170 to 200 liter of fluid through glomerular daily, which result only in excretion or formation of 400 milliliter to 2000 of urine. That means much amount, the bulk of filtrated volume will reabsorb. Bicarbonate is one of the major important buffer in the body, and also involved in extracellular volume homeostasis. However, does not have a transporter at the apical side of the renal tubules. So, to reabsorption, it must be reformed, and that usually achieved by binding of bicarbonate filtrate into the lumen with hydrogen ions secreted into the lumen, mainly through the sodium hydrogen ion exchanger. Then this binding will result in the formation of carbonic acid H2CO3 in the lumen of the renal tubules, where there is enzyme carbonic anhydrous that dissociate it into H2O and CO2 gas. CO2 diffuses freely through the membrane into the cytoplasm of the epithelial cell, where there is cytoplasmic carbonic anhydrous that converts it again into H2CO3 that is dissociated into bicarbonate. So bicarbonate in the lumen will be transported into the intracellular of the epithelial, but by formation of carbonic acid and reformation again of bicarbonate. So there is no direct reabsorption of bicarbonate due to absence of co-transport. The secretion of hydrogen ion into the lumen, as mentioned before, in the proximal tubules, usually with net final reabsorption of bicarbonate, referred to renal acidification. And approximately 70 to 90% of filtrated bicarbonate will be reabsorbed by this way in binding with hydrogen ion. Also, at proximal, hydrogen ion will react with ammonia that is filtrated, and it is a result of deamination of amino acid will be titrated this ammonia into ammonium by its reaction with hydrogen ion. So, hydrogen ion will titrated ammonia into ammonium. Hydrogen ion will involve in what? In reformation of bicarbonate and its reabsorption. The test of renal function, the first glomerular function test, the traditional and classic kidney function test usually used in routine work are serum creatinine and serum urea. These two parameters show characteristic changes in kidney failure, but they are not reliable indicator of acute kidney injury, as we will see. Creatinine, what is creatinine? Creatinine is the end product of creatine. Creatine usually is stored in the muscle as creatine phosphate synthesized in the liver and other tissues, and stored into the muscle as a source of immediate energy when there is need. When there is need of energy, creatine phosphate will be converted into creatine with formation of ATP. creatine around 1 to 2% daily of creatine will be converted into spontaneously and irreversibly to creatinine. So creatinine is the end product of creatine phosphate energy stored into the muscle. This formation of creatinine from creatine phosphate is usually at constant rate, and this is very important or advantage for creatinine as marker for renal function. Also, creatinine is completely filtrated by the kidney, and it is never reabsorbed by proximal or distal tubules, and so the plasma concentration of creatinine is inversely proportional to the glomerular filtration rate, the rate of filtration. That means halving of GFR result in doubling of serum creatinine concentration. And also this is advantage for creatinine as a marker for creatinine filtration rate assessment. However, the creatinine concentration is affected. That means has a disadvantage. That is, it is affected by age, by gender, by race, by muscle mass, and by eating of excess amount of meat and several drugs. According to the age, creatinine is only affected beyond the age of 60 years, while between 18 to 60 years usually is at constant level or very stable. Mentioned the advantage of creatinine is never reabsorbed, absolutely not reabsorbed along the renal tubules, but the disadvantage it is its secretion between 7 to 10% by renal tubules, and this will overestimate the serum creatinine when using as a marker of glomerular filtration rate. Will not overestimate the serum creatinine measurement, but will overestimate the creatinine clearance, a marker of glomerular filtration rate. Also, creatinine is increased in chronic kidney disease, but not in a linear fashion. That is mean will not increase in proportional to the loss of nephron number. And so around 70 to 80% of nephron damage till the beginning of increase of creatinine. Also, it is not a marker of acute kidney injury for this reason, and as a net result, normal serum creatinine does not necessarily indicate normal kidney function. Even its increase usually refer to impaired kidney function. So creatinine has advantage and disadvantage factors. Cystatin C is a low molecular weight protein synthesized by many or all nucleated cells in the body, and several workers demonstrate its superiority in assessment of kidney function over that of serum creatinine. And now cystatin C start to use in a routine work along with serum creatinine in evaluation of. Urea is the end product of protein substance, amino acid substance, and also account for 75% of non-protein nitrogen excretion. That means, for example, a nucleotide, also nitrogenous neurotransmitters, any substance that is not a protein or amino acid, but having a nitrogen, 75% of its end product is urea. So urea, it is not only the end product of protein and amino acid, but also of other non-protein nitrogenous compound. Urea is freely filtrated through the glomerulars, but the disadvantage is around 40 to 70% of urea is reabsorbed again. And the reabsorption of urea by proximal tubules is usually inversely proportional to the rate of filtrative flow, where there is an increase in filtration, that means increase in GFR, such as in pregnancy, the reabsorption will be decreased, and vice versa. And this usually gives the urea poor indication for assessment of kidney function or as a marker of glomerular filtration rate because of its reabsorption. So creatine is better than urea. For this reason, creatine is not reabsorbed to any degree, while 40 to 70% of urea will be reabsorbed. So the serum urea, the marker urea as a GFR marker is poor compared with serum creatine. However, it's used in dialysis outcome is better than of creatinine. Why? Because it is easily transported across the semimembrane of the urea concentration. It's affected by the rate of production. As mentioned, it is the end product of protein, usually amino acid derived from protein catabolism. Deamination of its result in formation of ammonia toxic. Ammonia will be converted into urea, into the liver mainly by urea cycle, or into the brain by glutamine pathway. As a result, ammonia will be converted into a less toxic substance, urea. So urea affected by the protein, by amino acid production, and its level into the blood will be related to the rate of production. And the urea in blood increased by high protein diet. High protein diet, that means high catabolism. Also an increase in endogenous protein catabolism. An increase by reabsorption of blood protein due to the GIT hemorrhage. All these protein diet, protein endogenous, for example, catabolism during chemotherapy treatment, or GIT hemorrhage, all these result in an increase in catabolism of a protein and the formation of amino acid. That is, end product is urea. So urea increased in the blood in condition not related to the kidney function or kidney structure. Also, when there is congestive heart failure due to decreased blood flow or treatment by cortisol. Cortisol lead to catabolism of protein. Cortisol is a proteolytic hormone. All these factors not affected the serum creatinine level. So creatinine is better than urea because it is minimally affected by extrarenal. Urea removal from the circulation can be reduced due to any cause of hypovolemia, including pre-renal, renal, or post-renal. However, the use of the ratio of urea to creatinine, it is useful in diagnosis and differentiation between the causes of acute kidney injury. For example, in obstructive post-renal condition due to a bladder tumor, due to the nephrolithiasis, stone anywhere in urethra, in ureter, and also prostatic benign hypertrophy. All this will lead to what? Outflow obstruction of the urine and result in an increase of urea and creatinine. Workers indicated that urea will be increased much more than creatinine, so the ratio of urea to creatinine will be high. According to our practice, we found that in post-renal obstruction in this condition I mentioned before, urea to creatinine ratio will be decreased due to much increase of creatinine than urea. And I interpreted that as all amount of filtrated creatinine will be excreted, while 40 to 70% of urea will be reabsorbed. And so the outflow obstruction due to a tumor of prostate, to tumor of bladder, to the stone will affect creatinine more than that of urea. That result in a ratio of urea to creatinine low. The normal ratio of urea to creatinine is 49 to 81 millimole urea per millimole creatinine, which account for 12 to 20 milligram urea to milligram creatinine. For example, in pre-renal causes of acute kidney injury, this ratio will increase. Actually will increase. Why? Because urea will be increased to a level beyond that of normal range. May approach 70, 60 milligram per deciliter when the normal range is up to 45. While creatinine usually remain within the normal range. Why? Because pre-renal is usually due to what? Due to decrease in the rate of filtrative flow. And as urea absorption is affected by the rate of flow in inverse proportional, so much amount of urea will be reabsorbed. More than 40, maybe 80 to 90 will be reabsorbed, result in an increase in the blood level. While creatinine is absolutely not reabsorbed. As a result, creatinine level will not be affected and the ratio will be increased. While in intrinsic kidney injury, for example to ischemia, both will be increased urea and creatinine. So the ratio is very important in differentiation of these. Uric acid is the end product of nucleotide, and it is usually its excretion depends mainly on the renal. The renal excretion, it is complex filtration and reabsorption. Again, secretion result in net excretion of uric acid about 6 to 12. This is the cause of abnormal urea creatinine ratio due to extra-renal, mainly extra-renal condition. For example, high protein intake, high protein reabsorption after GIT hemorrhage, high protein catabolism due to tumor chemotherapy, dehydration, muscle wasting. All this increase urea with normal maybe of creatinine. The ratio is high. While decrease in protein intake for malnutrition, malabsorption, or for example severe liver disease that result in stopping of urea formation in urea cycle that is occurred in the liver, or dialysis, or result in what? In low urea to creatinine ratio. Glomerular filtration rate is another parameter of kidney function assessment. It is the most reliable and the measure of functional capacity of kidney, and usually it is more sensitive, more specific marker that reflecting the intact number of nephron present in the kidney. And the rate of formation of glomerular filtration rate depending on the value of hydrostatic pressure, the contractility of the heart, and on oncotic pressure that mainly depending on serum albumin level. Glomerular filtration rate or renal clearance of a substance is defined as a volume of plasma from which the substance is completely cleared. For example, creatinine. The rate, the volume of plasma from which the creatinine is completely cleared, that is mean filtrated and removed by the kidney per unit of. Usually a decrease in GFR precedes the kidney failure in all forms of progressive disease. And the measuring of GFR in established disease is useful in targeting treatment, in monitoring progression, and in predicting the point at which there is need for renal replacement or dialysis, and also in defining the dose of drugs to prevent toxicity. So GFR, glomerular filtration rate, is the best biochemical marker for evaluation of kidney function. It is better than serum creatinine and serum urea. There's two forms of GFR. Measure GFR, that's need for equation urine level of substance, volume of urine over 24 hours, and plasma concentration of a substance. So it is involved the measurement of a substance like creatinine in urine and in plasma, and with accurate collection of urine for 24 hours, and usually expressed in mil per minute per square meter, which reflected body surface area. The body surface area usually obtained in general 1.73, depending on the weight, on the height, even may not involve all population. The best marker of glomerular filtration rate, it is inulin. It is a polymer of carbohydrate fructose, and it is not metabolized from intake to excretion, not reabsorbed, not secreted. It is the ideal marker, the gold marker. However, its disadvantage, it is exogenous substance. Most commonly used in routine work marker for glomerular filtration rate is serum creatinine, and referred to creatinine clearance. Creatinine is endogenous substance, usually completely filtrated or released by the glomerular filtration, never reabsorbed, and its formation from creatine as measured at a constant rate, so it is a marker of glomerular filtration rate. However, also it is cheap. However, its use has disadvantage as mentioned. That affected the value of glomerular filtration rate: gender, age, muscle, nutritional state, also analytical method. It is complex, and several methods was obtained to give a also, as mentioned, 7 to 10% of creatinine is secreted by the renal tubules, and this amount will overestimate the glomerular filtration rate when compared with inulin. Also, in addition, when there is overgrowth of the bacteria in the small intestine, the clearance of creatinine will become also important, that further affect the value of GFR. Consequently, serum creatinine measurement will not detect people with mildly reduced GFR, that's means stage 2, and will fail to identify many people with a chronic kidney disease at category or stage 3. Because of these limitations, it is recommended that serum creatinine measurement alone is not used to assess kidney function. Also, the use of creatinine or other biomarker, inulin or others, in GFR, measured GFR, has disadvantage of time urine collection. The correct collection of urine for 24 hours depend on the subject, and it is difficult, and that is give the GFR a negative indication.